Good afternoon. My name is David Dukas, and I'm the director of the program in Medical Ethics and Human Values here at Tulane University School of Medicine. I'm very pleased to do the sort of the background information on the J.R. Williams lecture before we get to Dr. Norko's presentation on compassion as an ethical and spiritual practice in medicine. Stephen, next slide. So the J.R. Williams Senior Fund was created by the Williams family, most notably by J.R. Williams Jr., who just passed away in the last couple of years. The fund was initiated with its first lecture back in 2013 with an endowment supporting lectures in spirituality and health, but focusing broadly on the art of creating a compassionate and trusting relationship between patient and doctor. The reason why is because there was a long legacy of J. Richard Williams, who was a Tulane University graduate, who was a beloved internist and oncologist in Selma, Alabama. Next slide. As a result of his oncology background and back during the earlier days of oncology, unfortunately, since there was less curative medicine back in those early days, there was far more palliative care medicine. So Dr. Williams loved medicine and took a large-scale interest in the impact of spirituality on health, particularly on how spirituality impacted the well-being and continued health of those who had suffered the loss of a loved one. If we could turn off all microphones, mute. Ashley, if you could turn off your mic. Next. And so now I'm going to turn this over to Dr. Stephen Hansen, who is the Director of Graduate Studies in our Master in Bioethics and Medical Humanities. Stephen?
Thank you. We are, yes, and our master's program and our up-and-coming graduate certificate program are also co-sponsors for this talk. I'm going to give you the nickel version of who we are so that we can save as much time as possible, but please, if you are at all interested in our program, tulane.edu/bioethics. Also, we have a variety of videos, including some of the prior lectures in this series available on YouTube, also on our website, but just search for Tulane Bioethics on YouTube. This particular talk that you could find on YouTube is a much longer presentation about what our program is and what we'd be able to offer if anyone is interested in looking into a Master of Science in Bioethics or Medical Humanities, or indeed a graduate certificate. We have that to offer, and this link will tell you a lot more about that. You can also get that by searching for us on YouTube. Like I said, I'll give you the nickel version. We have two tracks in our master's program, a bioethics track and a medical humanities track, because we recognize that both of these are important parts of understanding the humanities aspect of medicine. So if our students that focus on bioethics, we train them so that they can become hospital ethics committee members, IRB members, or working and teaching in ethics in pretty much any healthcare setting, and also doing research in healthcare ethics issues. Medical humanities track focuses more on the non-ethics humanities related issues, history, narrative, literature, film, and our students in this are being prepared to teach or research on all aspects of narrative, reflective writing, fine arts, and history as they apply to healthcare. I did say we have a master's program. We do, and that comes in a couple of different flavors. We have students who are taking the master's alone, usually straight out of a undergraduate degree, but some people who are taking it as a mid-career professional who are learning, who have recognized perhaps in their clinical careers the importance of ethics and humanities in it and want to know more so that they can take their careers in the direction that they want them to go. We also have students who are dual degree students earning their MD and MS at the same time. And the way that Tulane has that work, you take just the same 4 years to collect 2 degrees as you would to collect just the MD degree. And we are starting in the fall or perhaps the summer, crossing our fingers, offering graduate certificates in clinical ethics, research ethics, and in medical humanities. Learn more about those through that tulane.edu/bioethics website. Or contact me or Sofito Fingenden, and we'll be more than happy to answer questions for you, talk to you about the program, anything we could do to help you, educate you about what we might be able to do for you and with you. Let me say, without then any further ado, let me turn it over to Mary. If you are ready, I will stop my share if you'd like, and I will allow you to introduce our speaker.
Well done.
Thank you, Dr. Hansen. I have the honor of introducing a colleague and good friend of mine, Dr. Michael Norko. He's a graduate of Johns Hopkins University and received his medical degree from SUNY Upstate Medical Center, and also has a Master of Arts degree in religion. He's currently professor of psychiatry at Yale University School of Medicine in the Law and Psychiatry Division. He directs forensic services for the Connecticut Department of Mental Health and Addiction Services, where he oversees public sector forensic psychiatry services. He's also the editor of the Journal of the American Academy of Psychiatry and the Law, and a distinguished life fellow of the American Psychiatric Association. He's past president of the American Academy of Psychiatry and the Law, and past chair of the forensic division of the National Association of State Mental Health Program Directors. He chairs the Psychiatry and Religion Committee for the Group for the Advancement of Psychiatry. He shared the 2013 Guttmacher Award of the American Psychiatric Association and the American Academy of Psychiatry and the Law for outstanding contribution to the literature in forensic psychiatry. He's published and presented nationally and internationally on a variety of topics related to psychiatry and the law, and as well as medical and psychiatric ethics, public sector, forensic psychiatry, and religion and spirituality in psychiatry. I've come to know Dr. Norko better as we both serve on the American Psychiatric Association caucus on religion, spirituality, and psychiatry. He has a much longer list of kudos and qualifications, but at this point in time, I introduce him, and it's my honor to do so, and I thank him for sharing his expertise and observations with us today.
Well, thank you, Mary Lynn, for that kind introduction, and thank you all for inviting me. It's a pleasure and an honor to be with you for this lecture commemorating Dr. Williams' life and career. Let me share my screen and make sure that we're doing this right. Are you seeing it in the proper format?
Yes.
Okay, very good. So I'm going to talk about, obviously, as the title suggests, compassion as an ethical and spiritual practice in medicine. I'm going to draw on examples from my own area of practice, forensic psychiatry, but I also hope to generalize this more and also tell you that this is really applicable to all of healthcare and not necessarily just for physicians, although I will have a lot to say about physicians. I have no conflicts of interest to report. So this is our, these are the subjects of the talk today. And the question is, how do they fit together? Now, this is going to be hard to describe in a linear fashion. So the path through our talk today is not going to look like this. It's going to look more like this. We're going to be doubling back, talking in parallels, coming back on subjects, but this is also more consistent with a spiritual journey, so I think it's appropriate. All right, so to begin with, let's take compassion out of the picture and just talk about ethics and spirituality and ask how they fit together. So are they like Stephen Jay Gould's description of the non-overlapping magisteria related to science and religion? In that analogy, ethics would play the part of science and spirituality would play the part of religion. And in thinking about ethics playing the part of science, we would be thinking about ethics from a basis of an emphasis on facts, as opposed to spirituality with an emphasis on values. So to continue with that discussion of the possibility of thinking of ethics playing a role similar to science, I think we would start with discussing ethics as principlism. And of course, you're all aware of these principles outlined by Beauchamp and Childress. And each of these can and has been measured as facts. Right? So we're well aware that we can talk about autonomy in the sense of HIPAA compliance or reporting non-compliance, measuring whether informed consent has been obtained adequately, measuring whether patients actually understand what they supposedly have consented to, and we've all seen studies like that. Of course, non-maleficence and beneficence can be studied through outcome studies, through the reporting and study of adverse drug reactions, quality of life improvement with treatment, and any number of other outcomes. And in terms of justice, we can and have looked at things like health equity and disparity in terms of access to care, outcomes of care, and the economics of care. But it's also just as possible to talk about ethics in the sense of values. And one way in which that occurs and has occurred in the discussion about ethics in forensic psychiatry is to talk about ethics as professionalism and identity. My colleagues Phil Candilis and Rick Martinez have written extensively about robust professionalism in forensic psychiatry, which is an integration of personal morality with professional identity and integrity. In an article in 2005, they wrote that robust professionalism goes beyond an aseptic assessment of the forensic question to include an openness to the multiple aspects of the subject's suffering. Nearly 40 years ago, forensic psychiatrist Richard Ciccone and his colleague Colleen Clements wrote about the high degree of professionalism that is necessary to achieve understanding in forensic psychiatry of the individual and the situation. So it may be that there are really more overlapping magisteria. So if we stop thinking about ethics playing the science-based role on facts and think about it in terms of values and spirituality as values, then these clearly overlap. And the extent to which they overlap will vary in individual circumstances depending on the people involved and the context. So this brings us to the discussion of ethics and spirituality. Now, some of you may recognize this picture and others won't. It depends on how old you are, perhaps. This was a television ad that was popular in 1981 when I was in medical school. And it featured a young woman walking down the street with an open tub of peanut butter, as apparently young women in the 1980s often did. And a young man who's carrying a chocolate bar in his hand bumps into her. And she says, "You've got your chocolate in my peanut butter." And his response, of course, is, "You got your peanut butter on my chocolate." And the tagline to that commercial was, "Chocolate and peanut butter, two great tastes that taste great together." So I'm going to update that to talk about ethics and spirituality as two great values that work great together. So now, if you're starting to think ahead, perhaps you're wondering, is this what he's getting at? So we'll see. I think we need to spend some time talking about spirituality in medicine. We spend a lot of time talking about ethics, and I think that's pretty much a given, but not as much talking about spirituality. But this discussion has been on the increase since the late 20th century. Of course, it always had been part of the discussion in past millennia, really, as healers and spiritual leaders were often the same person. But beginning with probably the Flexner Report in the early 20th century, science and medicine became more focused on science, and we had to rediscover it really in the late 20th century. And this occurred in Joint Commission requirements, American Psychiatric Association guidelines, objectives that were established for psychiatry residency, and the AAMC objectives for medical school. So I'm going to go through a couple of the AAMC reports that were relevant to this. In a 1998 report about learning objectives for medical students, the AAMC said physicians must be compassionate and empathetic in caring for patients. In all their interactions with patients, they must seek to understand the meaning of the patient's stories in the context of the patient's beliefs and family and cultural values. In a 1999 report, they said students will be aware that spirituality and cultural beliefs and practices are important elements of the health and well-being of many patients. They will be aware of the need to incorporate awareness of spirituality and cultural beliefs and practices into the care of patients in a variety of clinical contexts. They will recognize that their own spirituality and cultural beliefs and practices might affect the ways they relate to and provide care to patients. Pat Fossarelli, who was an internist as well as a minister, wrote that often ignored is that each physician has his or her own spirituality that gives meaning to his or her life. Although a physician might not believe in a personal God, he or she might believe in something, for example, a unifying or universal principle that transcends the individual person and the physical realm. The Jesuit Roger Haight expressed this in a way that was applicable to all people, not just medical professionals. Spirituality may be understood as the logic of a person's whole life in the face of ultimate reality. John Swinton is a Scottish theologian and ordained minister of the Church of Scotland. He's a former forensic nurse at a secure hospital in Scotland, and he's the chair in divinity and religious studies at the University of Aberdeen, where he founded the university's Center for Spirituality, Health, and Disability. He's published this Venn diagram to note the fact that all human beings have a spiritual dimension, and that everyone's spirituality is like some other people's spirituality, and also everyone's spirituality is like no other person's spirituality. So given that spirituality can be such a diverse topic, it has been hard in the literature to find definitions of it. A group of healthcare professionals got together for a consensus conference in approximately 2008 and eventually published this definition in 2009 that they came up with. Spirituality is the aspect of humanity that refers to the way individuals seek and express meaning and purpose, and the way they experience their connectedness to the moment, to self, to others, to nature, and to the significant or sacred. Now, this was followed by a European conference with similar goals in 2010 and an international conference in 2013, and they arrived at similar definitions, but both of those groups added the concept of transcendence to their definitions as well. Now, we don't often think about spirituality as part of our daily work. We rarely perceive ourselves as doing that. We think of ourselves as engaged in the work that we've studied, been trained in, worked hard at. And Gary Moon has referred to this as the resistance of self-sufficiency. In a broader context, Dietrich Bonhoeffer expressed a similar idea in 1944. Bonhoeffer was a Lutheran minister and theologian. He was arrested and imprisoned and ultimately executed by the Nazis, and wrote a series of papers from his prison. In them is this statement: God would have us know that we must live as men who manage our lives without him. Before God and with God, we live without God. Many of you are probably familiar with Daniel Sumacy. He's the director of the Kennedy Institute of Ethics and a professor of biomedical ethics at Georgetown University, and he's a former Franciscan friar. In 1999, he published this: if we are to be true healers, we must rediscover what it means for medicine to be a spiritual practice. Well, that brings us to the topic of medicine as a vocation. The Latin root of that word, vocatio, literally means a calling. And through the Middle Ages, this description of vocation was used only to describe the calling by God to religious ministry. But after the Reformation, it was applied to secular work in which love of neighbor leads to service through one's occupation. In the modern Hippocratic Oath is this statement: I will remember that I remain a member of society with special obligations to all my fellow human beings. The modern Hippocratic Oath also has this expression about calling: may I always act so as to preserve the finest traditions of my calling, and may I long experience the joy of healing those who seek my help. Christina Bukowski and Margaret Gunther have written about calling, and they say that becoming a physician is the result of a choice that people make to respond to the call, and that the basis of that choice is spirituality, and spirituality is also the basis of physicians' compassionate relationships with their patients. In a study that John Yoon and colleagues published in 2015, they found that 83% of primary care physicians and 81% of psychiatrists agreed that the practice of medicine is a calling. This is the next topic that I want to explore in terms of the spirituality of medical practice, about presence. This phrase here, the art of presence, is the name of the annual retreat that the George Washington Institute for Spirituality and Health, known as GWISH, holds in Assisi, Italy, for healthcare professionals and other healthcare providers to offer them, quote, respite and renewal, reflection and nourishment, and to allow them to reconnect with their original call to serve in the healthcare field. So presence is about being present not only to the patients, but also to the situation and the task and to ourselves in the process. And Bukowski has written, or as this was actually part of a talk that she gave, that it's necessary to prepare to be authentically present in encounters with patients, and that there were three elements of this. One is cognitive. in which one has to form the intent to be present and to be compassionate. The second is emotional, in which we become aware of our own woundedness, our own sense of loss, and our own experience of suffering. And the third is spiritual, connecting to our call to service, recalling our own sense of meaning and purpose, and our openness to the situation and the endeavor in which we're about to engage. Ronald Epstein has also written about presence in the sense of it being an attitude of attentiveness or mindfulness. And he's also described the characteristics of mindfulness in medical practice: an active observation of oneself, the patient, and the problem; critical curiosity; the courage to see the world as it is rather than as one would have it; a willingness to examine and set aside our categories and prejudices that we hold; humility to tolerate an awareness of our own areas of incompetence; a connection between the knower and the known; compassion based on insight; and again, presence. So clearly all of these are applicable to forensic practice. And this is one example of presence in forensic practice in the sense of bearing witness. Now, I think that bearing witness is part of all medical practice, but in forensic practice, there's a certain public component to this. So we have to be present to the narratives and the sufferings of others, and then we're expected to give public witness to the individual's pain and life circumstances, as well as to the concerns and understandings of the collateral observers that we interview. But in all healthcare, all patients wish to be heard. Everyone wants to have their narrative understood and appreciated. Everyone wants to be valued and to be cared for and cared about. So now we'll start moving a little more deliberately toward discussing compassion itself. First, we have to start with the fact that the terms sympathy, empathy, and compassion have overlapping etymologies. And they're used almost interchangeably in everyday language, but they do have more specific meanings. Shane Sinclair and his colleagues studied this in a group of patients receiving palliative care and produced some definitions based on the reports that they got from the patients that they interviewed. They defined sympathy as a pity-based response to a distressing situation that is characterized by a lack of relational understanding and the self-preservation of the observer. Hello, this is Michael Norko. Please leave a message and I'll get back to you as soon as I can. Thank you. I'm sorry that I have no way to shut that off. So let me continue here. Empathy, they defined, though, as an affective response that acknowledges and attempts to understand an individual's suffering through emotional resonance. Now, empathy has an interesting history in psychiatry. It was first described by Heinz Kohut in 1959. Although Freud had used the word einfühlen, meaning to find one's way into another state of mind, but he never elaborated on that concept. And Kohut defined empathy in a very interesting way, I think, as vicarious introspection. And I really like that definition. Kohut also emphasized that introspection or empathy can never be absent from psychological observation. So it's really the basis of the work that's done in psychology and psychiatry. Now, in forensic evaluations, obviously, psychological observation is a very important part of that task. And one of my forensic colleagues, Neil Kay, wrote this about empathy. I hope that each and every one of us is affected by the stories we hear from evaluees regarding their trauma. To fail in this endeavor would be inhuman and impede our goal of truly hearing what is being expressed during the evaluation. Now we'll turn more directly to compassion. Now, Thich Nhat Hanh, for those of you who don't know, was a Vietnamese Buddhist monk who spoke and wrote extensively about mindfulness practice. He just passed away this last month. And this quote is from a talk that he gave to prisoners at a correctional facility in Maryland. Understanding is the substance out of which we fabricate compassion. Now, if you remember a little while ago, we had the quote from Richard Ciccone and Colleen Clements that a high degree of professionalism was necessary to achieve understanding, and professionalism we were discussing as a form and structure of ethics. So you can see again this connection between these concepts that I'm talking about. In the Sinclair study, when they defined compassion, it was this way: a virtuous response that seeks to address the suffering and needs of a person through relational understanding and action. So empathy becomes compassion when some form of action and response is added to it. Reverend Swinton also advises us that we must see compassionately, because how we view the world shapes what we think we see and how we respond to it. Remember Epstein's comments about the relationship between the knower and the known. So this idea of how we see things shapes what we think we see and understand about the world, and then how we respond to it. And then Swinton says, compassion occurs when one has a deep awareness of the suffering of another, accompanied by the desire to bring relief. So some examples from forensic psychiatry about compassion. Again, Ciccone and Clements describe the importance of empathy and compassion to forensic ethics, to the expression of medical values, and to the goals of justice. Candelas and Martinez propose that the compassionate professional is one who is open to the multiple aspects of the subject's suffering, and that the professional is able to express empathy and compassion through narrative and humanistic language. Ezra Griffith is another forensic colleague who in 2005 also was writing about narrative and humanism in his essay, and asked us to sensitively recognize the pain and suffering of those we evaluate, recognizing them as one of us. And in his argument, he coupled this with action, that he argued that we not only need to consider the people that we evaluate and their disadvantage and disempowerment, but also in the process of doing that to strengthen our response of respect for persons in that situation and in general. Now, I have written about and privileged the place of compassion in forensic ethics and the spirituality of forensic practice. In 2005, I wrote a commentary on Ezra Griffith's article that I was just discussing, in which I talked about compassion as a core value in forensic ethics, and argued that what we need is an approach to justice that allows us to attend to and engage the humanity of all the subjects of our evaluations. And I argued that that approach was compassion. More recently, I've also made an argument that compassion is an essential element of the clinician's spirituality in a talk and paper about the spirituality of forensic psychiatry, arguing that it represents a call to service, an expression of meaning and purpose, a connection to self and others, and to what is considered significant or sacred. Reverend Swinton has said this very explicitly: compassion is a basic orientation that one chooses to adopt toward others. As such, compassion is a basic spiritual practice. So we provide an example in forensic practice. So often when forensic psychiatrists or other psychiatrists have to testify in probate court in either a civil commitment hearing or an involuntary medication hearing about a patient who's in a secure treatment facility, it's often necessary to describe in some detail the patient's medications refusals, lack of cooperation with treatment, agitation, verbal outbursts, violent behavior, etc. And in a journal club discussion that we were having about Swinton's work, the question came up, so in such a situation, when we have to provide all of this sort of negative detail about a person's life and behavior, how can the forensic psychiatrist be compassionate while still needing to describe all of these attributes? And the answer was in the Swinton material that we were reviewing. And it's the same quote that I just went over, that compassion occurs when one has a deep awareness of the suffering of another, accompanied by the desire to bring relief. So the job of the forensic psychiatrist is to convey that deep awareness and that desire for healing. And in the testimony, as well as that concern for the patient. And to do this through narrative and humanistic language, through tone and body language. And to achieve this result authentically requires preparation, mindfulness, centering, and humility. Now, in forensic psychiatry, as well as in other areas of medicine, there are some dangers of compassion. In forensic psychiatry, for example, Swinton has noted that opening up spaces for compassionate interaction can be dangerous, that we deal with people who may wish to manipulate or harm us as caregivers. In a internal medicine and palliative care dimension, Christina Pekalski recommends a respect for boundaries as the way to enable presence without risk of harm to self. Graham Glancy is another forensic psychiatrist. This last year, he published an article in which he recommended the concept of detached concern as a dynamic balance between clinical empathy and rationality, with practitioners self-monitoring and dynamically adjusting between these two attitudes. And Reverend Swinton recommends respect and care for oneself and times of withdrawal from the patient, but not abandonment as the way to deal with those. In talking about that, he uses the biblical admonition to love one's neighbor as oneself, but emphasizes the part of that that we often don't pay any attention to. That it's not just about loving neighbor, but it's also about advocating the love of self and the necessary value of respect and care for oneself. There are more particular dangers of compassion in forensic psychiatry, vicarious trauma being one of them, but vicarious trauma is clearly not limited to forensic psychiatry, but I'll just give this one example. John Bradford is a forensic psychiatrist from Canada. He's an expert in the evaluation and treatment of sex offenders, and he has been very open about talking about the effect that a series of evaluations had on him, and one in particular in which he was needing to review very graphic audio-video tapes of sexualized murders of young women, and it caused in him a profound depression and very serious suicidality that took him some years to recover from. And I won't go into the details about these other authors here, but each of them has written in some way about how they've dealt with vicarious trauma and what their recommendations are for being careful to protect oneself. And of course, this is all related to self-compassion. As Charles Sasser and Christina Pakowski wrote, keeping track of these costs requires self-awareness and a gentle acceptance of our human limits. Thich Nhat Hanh says that compassion to self is an important part of mindfulness. Walter Sipe recommends, quote, cultivating non-judgmental present moment awareness of one's experience, including sadness itself, unquote, to enhance self-compassion. Psychologist Kristen Neff has developed an assessment of self-compassion and practices to promote it, and it's available on the web. The website is self-compassion.org, and you might want to check that out and take the assessment and see how well you're doing. And if you need to work on that, there are various exercises there for that. Bukowski and Gunther also suggest asking these questions of oneself as part of self-compassion. What gives my life meaning? Why did I choose this profession? How do I care for my deepest self? And how am I restored after a day surrounded by suffering and loss? Simone Weil was a French activist, philosopher, and mystic of the first half of the 20th century. And this is her definition of humility, is compassion directed toward oneself, which I think is a very interesting way of thinking about humility. And it echoes Ronald Epstein's discussion of mindfulness in medical practice that we just reviewed a few slides ago. And I think this is a very important idea for physicians and other healthcare professionals to contemplate, because we can, by nature, be so very hard on ourselves. Simone Weil also wrote about compassion and justice. In an essay called "Are We Struggling for Justice?" she begins with a quote from the ancient Greek Thucydides, who wrote, "The examination of what is just is carried out only when there is equal necessity on each side. When there is one who is strong and one who is weak, the possible is done by the first, the one who is strong, and accepted by the second, the one who is weak." So she uses this as a springboard to argue that justice is found in the seeking of consent from the other in all of our interrelationships and all of our interactions with others. And then she has this quote: "The spirit of justice is nothing other than the supreme and perfect flower of the madness of love, which turns compassion into a far more powerful motive for any kind of action." She also wrote a statement of human obligations in which she notes that there is an irreducible societal obligation on all of us to respect all human beings and be concerned for their needs. As part of that statement, she writes this: "If any power of any kind is in the hands of one who has not given total, sincere, and enlightened consent to this obligation, such power is misplaced." Karen Armstrong is a world religion scholar and began the Charter for Compassion in 2009, calling on all people to, quote, cultivate an informed empathy with the suffering of all human beings. They have an active website. You can go on that website, you can sign on to the Charter for Compassion, and you can review their materials there. So, what are the conclusions that, or propositions that I hopefully have made some argument towards in this talk? First is that compassion is an ethical and spiritual practice of the whole physician or of the whole professional, integrating and identifying with one's vocation, values, purpose, and that which gives life and action meaning. Compassion is a core ethical value in medicine. And compassion is at the heart of the spirituality of medical practice. And of course, the most important take-home message from today, yes, compassion is a peanut butter cup. Now, I was going to stop there. And then yesterday, I received an email from the folks at the Charter for Compassion, the Charter of Compassion, and it had this big picture at the start of it, and then a message from their director of development, who was quoting her grandfather and saying, "I cast my bread upon the waters and it comes back peanut butter sandwiches." So I couldn't resist adding that to the end of my talk. And with that, I'll pause and invite questions and discussion.
All right. Thank you so much, Dr. Norko. Your gifts for multidisciplinary synthesis of not only your own insights, but other thought leaders never ceases to amaze me. So thanks for this presentation. If people would like, please enter any questions, comments into the chat box, and we can share those with Dr. Norko and see how we can continue the thoughts and the discussion during the remaining minutes.
Might I begin by noting we've seen multiple requests for your slides. Could we request a copy of your slides so that we could distribute them to folks? We'd be happy to do that.
Yes, I'll send those to you.
Thank you. Then anyone who wants them, you can get them from us, Tulane Medical Ethics at tulane.edu, or any of the other contacts here. And now I will hush and let you take questions.
Numerous comments reflecting appreciation for the talk. First question, when one studies complementary systems of medicine, the holism and lack of a mind-body duality is often apparent. Is the emphasis on compassion important as a response to the areas of health that biomedicine struggles with covering? I assume to this ever-present tendency toward a mind-body duality way of thinking.
Right. Yes, I think that's certainly true. You know, there are times when each of us appreciates the technical skill of our caregivers, and that's what's most important to us. You know, in studies that have been done about whether people want their physicians or their therapists to discuss spirituality with them, you know, there are always a range of answers to that question. And so, you know, people often say, well, in some certain circumstances, but not necessarily in others. And I think that's generally true. But there's also, there's no doubt that part of the healing process is not just the technical skill and expertise, but the way that the person feels enveloped by that expertise, and the caring attitude of the professional delivering it. So I think to that extent, no matter what we're doing, compassion always improves the healing process.
Okay, thank you. Next, observation and question. What role do you believe, Dr. Norko, that dealing and acknowledging outside factors such as systems of oppression, what roles do those considerations play in compassion towards patients?
Yeah. So this is actually a big topic in forensic psychiatry right now. There is a group of us that is working on a practice resource to actually deal with this, because there's a kind of a classic ethics conundrum in forensic psychiatry related to this, related to inequality and oppression. So one of them is, and these examples were brought up by Alan Stone famously. Alan just recently passed away as well. Many of you are probably familiar with his work. Alan raised the problem of Dr. Leo, who was a Jewish physician in early 19th century London, where the Jewish population was oppressed. And he would give testimony to try to alleviate the prosecution of his fellow Jews who might have been charged with theft because they were hungry and needed to feed their families. And this raises the question about whether, in Stone's mind, whether or not there was any ethics principle that helped us avoid twisting justice in order to serve social political ends. And in 1981, he actually, or was it 82, I think, he argued that psychiatrists have no place in the courtroom because we just can't do it. Now, there's been a whole development of ethics in the field since then, and most of the response deals with narrative, professionalism, humanism, and it's not the question of twisting justice, but the question of, as you know, and as Ezra Griffith has written extensively about, the problems faced by Black Americans and the inequalities in the justice system, and that it just reinvigorated him to be present in the courtroom, to not leave that marketplace, and to be able to give witness and sensitive understanding about the individual and the context of the individual's life. So, there are many other ways that we're thinking about this too, as we're beginning in this practice resource development. There are areas that we need to encourage in terms of research. There are things that we need to do personally outside the courtroom in terms of advocacy, whether that's legislative advocacy or funding advocacy or whatever it is. So yes, there are, compassion. As I said, the important element of compassion is the action, and so there are any number of actions that it's incumbent on us to participate in dealing with inequities and oppression in healthcare and in our society.
Thanks. As I mentioned in my introduction, you are a prominent forensic psychiatrist who is theologically trained and also an ethics expert. Can you say more about the use of forensic psychiatry, the lens that you've taken for this particular topic of compassion when it seems so broadly applicable across multiple domains of medicine?
Yeah. So, I've taken this lens because it allows me to speak authentically about the topic. I'm not an internist, I'm not a palliative care specialist, but I've introduced at least some responses from those people. Yes, it's clear that this is important in all fields. It's in forensic psychiatry, the first response to Alan Stone's challenge, the first really profound sense was by Paul Applebaum, who said that the principles we ought to utilize in a forensic ethics or truth-telling and respect for persons. And by truth-telling, he meant to be honest about what we say, but also to acknowledge the limits of what we're able to say. And by respect for persons, he meant really mostly just that we make sure that the people we evaluate understand that we're not there as their caregivers, that we're not there necessarily for our patients' benefit. But those ideas have expanded tremendously over time, and respect for persons now really seems to be, foundational to all of our discussion about narrative and humanism in forensic psychiatry. And so it provides us with a lens that reminds us that we are still physicians in the courtroom, because the previous sort of bent was to say, well, yes, we care for people in our offices, but once we get in the courtroom, we're just there to serve the ends of justice, and we can't really care about the people. I thought it was necessary as a corrective to that idea to discuss the fact, as others have, that no, we can't divorce ourselves from our identity as physicians and from the calling that we have to compassion for others. That should be part of what we do, and we just have to realize how to do that in different ways in different contexts.
Thank you. We do have a multidisciplinary group here. What has been your experience when you've talked about compassion or other elements of this talk with not only physicians and other specialties, but also providers, caregivers in other healthcare disciplines such as social work, nursing, respiratory therapy, et cetera?
Right. So, so all of these other disciplines have their own stream of compassion. They're all about human service. They're all about care of others, and people in each of those fields are as subject to the concerns that I talked about in terms of physicians. I mean, everyone's potentially liable to vicarious trauma, to compassion fatigue, burnout. So all of this is equally applicable, I think, there. It's just, since I'm not trained as a social worker or a nurse, it's more difficult for me to speak for those disciplines. But I think the same things apply there. And as well, importantly, the same concern for care for oneself as well.
I think we have time for one more question. So there's one here of practical theological nature. Dr. Norko, how do you think the possibilities of compassion, which sounds a lot like love, are limited by human self-interest, or are you thinking more theologically that they might be limited by sin? And any other thoughts related to difficulties having compassion and empathy regarding like practical kinds of limitations such as time constraints, efficiency pressures, I would add productivity,
Right.
those kinds of demands?
Yeah. Well, yes, all of those are legitimate questions and concerns. It's clear that there are practical limits to what any of us can do, and I've actually been gratified by John Swinton's theological advice about, the idea of love of neighbor should be the same as love of oneself, but that's founded on the idea that one has to care for oneself as well. And so we all have practical limitations. This is also deeply tied to Simone Weil's idea that compassion for oneself is humility. None of us is capable of everything. None of us has limitless energy or limitless time. And there are practical constraints to what we do. And yes, all of us are also bound by human frailty. And so we will all experience weakness. We will all experience moments of selfishness. Sometimes those will be expanded and enlarged by our feeling overburdened and overwhelmed. But I think the Jewish Institute has this right in their annual retreat, which, by the way, my wife and I had the privilege of attending in 2015, that part of the answer is to think back to why we chose this profession in the first place, and what our calling was. And although we're all given to moments of selfishness, that's not what called us to the healthcare profession. It was not, I mean, there might be one or two people out there who thought this would be a good way to make money, but that really isn't enough to propel people through all of the preparation experiences of training that are required to do this. There's really more driving it than that. At least that's what I believe about most of us.
Thank you very much, Dr. Norko, and we yield back to the Ethics Center leadership right now.
Thank you, Dr. Dell, and thank you, Dr. Norko.